IMG 340, head, cerebral vessels, and neck CT. We will begin by discussing some head and neck clinical indications. First is acute neurological dysfunction. This often presents as paralysis or stroke, or as a transient ischemic attack, which we will be referring to this with the abbreviation TIA. The neurological deficit can be commonly caused by cerebral infarction from blockage of blood vessels in the head and neck, by spontaneous brain hemorrhage or bleed from hypertension, or blood vessel abnormalities. An example of this would be an aneurysm. It is also commonly caused by infection or by primary or metastatic tumor. Cerebral infarction is the loss of blood supply to a portion of the brain. It is difficult to see the infarcted area in the early stages, and the earliest sign of infarction shows as a loss of gray-white matter differentiation, and it's more obvious with time as the infarct matures. So if a patient comes in with a suspected stroke and they maybe are just starting to show signs in the last hour, you will do a head CT often on them, not seeing any gray-white matter differentiation or any presence of a stroke. However, it is often very common to do another CT head 24 to 48 hours later to see if the infarct has in fact shown up later. And in these pictures here, you can actually see the gray-white matter differentiation in both of these pictures. This is evidence of a stroke. A hemorrhage is also known as a bleed, can be spontaneous, either because of an underlying vascular anomaly, such as a tumor or arterial venous malformation, abbreviated by AVM, or even because the patient's hypertension has weakened the walls of the capillary vessels and caused the bleed. Extravasated blood shows as increased density, so this will show as white. And you can see on the picture right here that the bleed is on the right side of the brain, and it shows as a high density area. The degree of effect caused by a hematoma is shown in the amount of brainstem compression from the shift of the midline. So here's the midline, right down the middle of the brain. If this bleed has caused this midline right here to shift, then it is a higher degree of effect. It affects levels of consciousness and is measured by the Glasgow Coma Scale. And this scale ranges from 3 to 15, with a normal score being 15. And obviously, the worst score being a 3. With a patient who scores even as high as a 13 or 14 on the scale, though, time is absolutely crucial, as the score can decrease in less than 5 minutes if there is an expanding intracranial hematoma. The tech should alert medical personnel if he or she sees a change in the person on the table that they are scanning that has a bleed. The hematoma will get less dense over time if the patient survives and everything goes correctly in their recovery process. The most common brain tumor is a metastasis, so it's a tumor that has started somewhere else in the body and then basically spread to the brain. As far as common examples of primary brain tumors, these would be a meningioma and a glioblastoma multiforme. The head CTs use the location and pattern used to predict the grade of these tumors, so how bad they are. In the cases of meningitis or encephalitis, it is useful to analyze cerebral spinal fluid for presence of cells and other compounds like glucose, proteins, antibodies, and bacteria and viruses. The lumbar puncture can be performed to analyze CSF, but can only be performed if the intracranial mass is already ruled out. A congenital brain abnormality is another head clinical indication. An example of this would be some types of seizures that are caused by cortical dysplasia. These are basically localized arrested brain development areas, and these are asymptomatic. Conditions affecting other components of the head besides the brain are commonly evaluated by CT, and these include the sinuses, mandible, and orbits. Regarding the sinuses, CT images are helpful to avoid the surgeon from inadvertently entering the brain or orbits during a sinus surgery that they are performing. And this surgery is often performed with direct correlation to CT images. The mandible isn't optimally viewed with plain films. It's very hard to see exactly what is going on with the mandible in general X-ray films, but it is much better seen on CT images, especially CT images that include 3D reformations. The orbits are important to image under CT imaging for similar reasons that the sinuses are. The CT images actually help the surgeon locate foreign bodies when they are doing a surgery inside the orbits. Next, we will discuss some of the cerebral blood vessels, clinical indications in CT. One common exam done is a CTA. This is also known as a CT angiography. This exam uses contrast to better visualize the blood vessels in the head and neck, so it really lights up the cerebral blood vessels on the CT images so they appear white from the contrast. Some of the blood vessels that are imaged are the subclavian and vertebral arteries, the common carotid artery bifurcations, which this is a very common stenosis site, the internal carotid arteries, the intracranial arteries, which this is a common aneurysm site, and these include the anterior, middle, posterior, cerebral, basilar, and cerebellar arteries. And another set of common veins or arteries is the jugular veins and the dural sinuses, which these are sites of possible thrombosis. A CTA is usually easy and convenient, and it can be done quickly. An important use for a CT exam is in suspected acute cerebral infarction because fast intervention may result in actually a significant lessening of the extent of the brain damage. So if the exam is done quickly and the results are sent to the ordering doctor quickly, then intervention can occur and less brain damage will occur as well. After a non-contrast CT head is performed to rule out a hemorrhage or bleed, a CT perfusion at the level of the suspected infarct is obtained to delineate the amount of brain at risk for permanent damage. So once that CT head without contrast is done, then a CT perfusion scan can be done. A CTA of the cerebral vessels will sometimes follow to identify the presence of a clot in a major intracranial artery before a clot-busting drug is administered. These clot-busting drugs are commonly known as thrombolytic agents, and you may have heard of them in the clinical field. One of the neck indications that we will discuss are masses. They can occur along lymph nodes, along nerves, or even adjacent to vessels. A goiter is another clinical indication, and this is enlargement of the thyroid gland, and it is a frequent incidental finding when imaging the neck for any reason. So if a patient is getting a CT of the neck for some reason other than looking for the goiter, a goiter can still show up on the scan and provide good clinical information to take care of that. Goiters can actually cause airway obstruction if they are large enough. Infections are another clinical indication for the neck. This may start in the disc space at any level of the spine, and they can spread to the epidural space, causing an epidural abscess, which can result in spinal cord compression and paralysis, which is very serious, as you know. The infections can obstruct the airway or cause difficulty swallowing and drooling. Post-procedural CT scans of the many types of spinal interventions described previously are common to assess results of the procedures. I just want to do a quick review of some of the anatomy for the different body parts that we're discussing in this chapter. For the head anatomy, transverse images are important. They use a standard algorithm, and the slices that are imaged are through the base of the skull, and it shows detail of the foramina, facial structures, pituitary fossa, and temporal bones. Cerebral spinal fluid are in the basal cisterns, and the ventricles are shown, and differentiation of white and gray matter. The coronal images are useful as well, and they're useful in assessing bone, particularly when the plane of bones runs parallel to the axial slice. An example of this is the floor and the roof of the orbit, the skull base, and the top of the cranial vault. The pituitary gland is also well defined in the coronal images, as well as the cella turcica in itself. The coronal images of the temporal bone can also highlight the relationships of the ossicles and the structures along the medial wall of the middle ear. For neck anatomy, IV contrast is usually used to enhance the certain structures that are being focused on. Some major vascular structures that are usually imaged with the IV contrast include the carotid arteries and the jugular veins. Superficial mucosa in the submandibular glands and the parotid glands are also shown well with IV contrast in the neck. Thin sections of the larynx show relationship of the cartilage to the adjacent soft tissue in the neck. This slide right here you will see pop up in other lectures as it is kind of a universal slide. Patient preparation is very common from one site of anatomy to other sites, so it's pretty standard. And we'll go over them right now. First, you need to remove any metallic objects from the patient. The scanned area should be free of all jewelry, hairpins, metal gown snaps, glasses, and wires attached to the patient. They can be moved out of the scan even after the topogram is done without having to redo the topographic image. So basically what that means is that if you do a scout or topogram, then you see that the patient has maybe some hairpins in or hearing aids right in the area of anatomy that is being imaged, then you can actually have the patient remove those objects without having to start over and redo the topogram. Fasting isn't usually necessary, but also you don't want the patient eating a large meal before a contrast study in case the introduction of contrast causes vomiting and nausea, which it is sometimes known to do. You want to have the patient empty their bladder, especially for a longer CT study. You want to ease the patient's anxiety by staying calm during the exam and giving them the description of what all will be occurring during the exam. You might find in CT that many patients confuse CT with MRI before they actually get into the room. They may be extremely anxiety-ridden or maybe nervous because they may think that they are going in a long tunnel, which is more claustrophobic for some patients than others. So you want to definitely make sure that you're explaining the exam properly to them and showing them the differences possibly between MRI and CT, and that this won't be too bad on their claustrophobia. You need to review any known allergies and renal function before injecting contrast to minimize reactions and also kidney impairment. Make sure you know any cardiac medications because these can indicate poor cardiac functions, which actually can be relevant during a CTA exam. You need to be able to get the patient in a comfortable position in case the exam takes a longer amount of time. Usually most scans don't take too long, but you do want to get the patient in a comfortable position. Have the patient close their eyes if using a laser to position. This is extremely important on CT head images and maybe the neck as well, if that laser, the positioning laser, will interact with the eyes at all. With challenging patients, you need to sometimes use restraints with combative or uncooperative individuals. And you'll also sometimes have to use body fluid protection such as gloves, masks, and gowns. So you're usually going to position supine for the head and neck and cerebral vessels. The patient is usually going to be centered accurately from left to right in the head holder and from front and back. And you'll sometimes have to use positioning sponges. Prone positioning is sometimes necessary for imaging, especially in the case of the paranasal sinuses, sella turcica, and some CT-guided procedures like biopsies. Decubitus is rarely used, but only usually used when the patient can't lie supine, and the images actually need rotated after the exam, so this is more work on the back end as well. You need to use cushions or folded blankets as extra stabilizers. This is especially true for kyphotic patients where they have that large curve to the back. The tech must center the area to be scanned in the middle of the gantry, horizontally as well as vertically. The tech must choose correct field of view for the anatomy being scanned. and the techniques to ensure that restraints or blankets don't interfere with the detectors to produce inaccurate CT numbers. This also can come into play if your CT machine has a safety feature where, for example, I know that our CT scanner that I work on has a safety feature that actually shuts down the scan. It completely stops the scan if anything touches inside the gantry. So, for example, if we have a patient on a backboard and they're a larger patient and blankets and restraints and all kinds of things go through the gantry during the scan, if one of them touches the inside of the gantry, then it stops, and the scan actually has to be started over once we reposition everything. So for head scanning protocols, CT scanners are equipped with preset protocols and techniques in a variety of slice thicknesses, which may vary depending on the model and the manufacturer. Adjustments to the radiation dose can be made according to the patient's size. Standardized department protocols are usually developed in collaboration with the radiologist, and they help to ensure image quality and to also facilitate patient throughput. Two transverse scanning planes that are widely used are the OML, which is the orbital meatal line, and this joins the infraorbital rim to the superior border of the external auditory meatus, and this results in better images of the orbits, sella turcica, posterior fossa, and brainstem. The canthomeatal line is also commonly used, and this joins the lateral canthus of the eye to the center of the external auditory canal. So the OML and the CML are two common sites where you will place the laser for positioning for the head. In children, you'll often want to use a 20 to 25 degree angle to the OML or the CML to avoid radiating the ocular lens, which can lead to early cataracts. The transverse plane is the most used plane for image interpretation of the skull and its contents. If reformatted images are required, it is better to acquire thin slices initially and then reformat the images. This technique is often used when scanning the orbit, so the lenses of the eyes are only scanned once, and then you can get your reformations from that scan. This also allows the patient to be in a possibly uncomfortable position for a shorter period of time. Coronal sections are useful when structures that run parallel to the transverse plane are assessed. The algorithm or kernel chosen will affect the resolution of the images. Lower MA techniques can be used to evaluate the paranasal sinuses or facial bones, such as for fractures. However, temporal bones need a higher MA technique to get accurate details, since this is the densest bone in the body, and since it has really small structures such as the cochlea, the semicircular canals, and the ossicles. Contrast enhancement is not visible on bone algorithm or bone windows. Also, when contrast is used, images on soft tissue algorithms are also required to see the enhancing tissue, such as within sinus tumors and chronic sinus infections. It used to be that the transverse plane was the preferred plane for interpretation of the neck and blood vessels, but now multiplanar reconstructions in coronal, sagittal, and oblique planes greatly enhance the radiologist's ability to diagnose. So to avoid artifacts on soft tissue algorithms caused by dental artifacts and capped teeth, the technologist should tilt the gantry to avoid these artifacts if possible. IV contrast helps distinguish blood vessels from lymph nodes and muscles. Metastatic lymph nodes are common in the head and neck cancer. Patients with neck masses often cannot lie supine due to difficulty breathing, and special phonation techniques are occasionally used to assess the mobility of the vocal cords. So after a normal scan, the level of the true vocal cords are determined, and then a limited number of slices are acquired while the patient vocalizes E, 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 E in expiration, or a reverse E, 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 E in inspiration. Bone algorithm of the cartilage of the neck is sometimes requested to evaluate the cartilages surrounding the larynx for fracture or dislocation, possibly from a blow to the neck. Reformatted sagittal and coronal images depict the cartilaginous abnormality to best advantage before repair. Salivary glands, including the parotid glands, submandibular glands, sublingual glands, and minor salivary glands, are sometimes evaluated for benign and malignant tumors, as well as for obstructing calculi. CTP, which is CT brain perfusion, this is a perfusion study that we mentioned earlier in the presentation, and is best used when a suspected acute brain infarction has occurred. It usually is followed immediately by a CTA. The CTP and the CTA both require injection of a bolus of contrast. If getting both a CTP and CTA, the amount of contrast must be limited and balanced for each exam. So, for example, the CTP may require 50 mLs of contrast, while the CTA requires 100 mLs. However, a CTA with a CTP receives 100 to 150 mLs of contrast collectively. A balanced area of brain is repeatedly scanned, usually 2 to 4 locations, during the first contrast bolus for the CTP. These levels are determined by the radiologist from the findings on the unenhanced CT and from the presumed area of infarction. Bolus tracking is used in a CTA to time the image acquisition to the peak of contrast in the cervical vessels by sampling the carotid just below the skull base. This is immediately followed by the second bolus and acquisition of images from the aortic arch to the circle of Willis. The tech can produce maximum intensity projection images, also known as MIP images, or 3D surface shaded images, while the radiologist evaluates the CTP study using separate software provided by the manufacturer. Values of cerebral blood flow, blood volume, and mean transit time are determined by the radiologist to further evaluate the brain infarction and the amount of potentially salvageable brain. Although the preset techniques and protocols supplied by the manufacturers are helpful, the tech must be able to manipulate the MA, KV, helical pitch, scan time, and the slice thickness to suit every circumstance. Increasing the MA and KV will improve the signal-to-noise ratio. A high technique is necessary for contrast resolution of soft tissue in the brain, or in other words, gray-white matter differentiation. Increasing the scan rotation time will result in better resolution because each image is generated from more projections. Increasing the helical pitch actually results in a shorter scan time, but reduces the overall image quality because of more interpolation in the scan data and vice versa. Longer scan times can result in longer tube cooling and the possibility of patient motion, which this can be often due to back pain. Slice thicknesses should be adapted to the area of interest regarding the anatomy. Studies that need reformatted images are acquired helically with thin slices. This is useful when imaging the brain petrous bones and the neck masses for better resolution. The transverse sections show the base of the skull well, as we mentioned earlier, and this gives excellent detail to the temporal bones, pituitary fossa, facial bones, and foramina. Thicker slices increase the definition of gray and white matter in the brain. Spatial resolution is improved with thinner slices, but at the cost of a decreased signal-to-noise ratio. Yet, increasing the MA and the KV improves the signal-to-noise ratio, but it also increases the radiation dose, so you need to be careful of that. Average slice thicknesses of the brain is usually anywhere from 2.5 to 5 millimeters. Orbits are studied with 1 to 2 millimeter slices, so the orbits usually need better detail, so they have thinner slices, and a small field of view is often used, usually 13 to 15 centimeters. The CTA image acquisition utilizes 1 millimeter helical slices, and the CTP uses a cine mode and uses 5 to 10 millimeter thick slices. The matrix size is predetermined, usually at 512 by 512 on most current equipment, although some systems do have a 1024 by 1024 matrix. The three basic algorithms used for the brain, neck, and spine are the standard bone and detail algorithms. Standard algorithm is chosen for most soft tissue imaging, such as the brain and the intervertebral disc spaces, because it provides good contrast resolution. It is important to distinguish gray from white matter when looking for acute cerebral infarction, as we've said before as well. The detail algorithm is useful when studying the soft tissues of the neck, and this increases edge definition. The bone algorithm is used to increase the sharpness of the bony detail, and it optimizes facial resolution, but in trade-off, the contrast resolution is poor. It should not be used in isolation when the IV contrast is given because tissue enhancement is not visible on bone windows or bone settings. IV contrast has been used since the early days of CT scanning to improve visualization of normal and abnormal structures. Abnormal tissue can enhance either because the blood-brain barrier has been breached, as in the form of a malignant tumor possibly, or because of an inflammatory process. An example of this is scarring in a post-op spine procedure. The degree of enhancement is related to the method of contrast administration and the dose and concentration of the contrast received, and as well as the delay between the contrast administration and the image acquisition. So, for example, there are two types of administration methods for contrast. One is a drip infusion, and the other is a bolus pump infusion, and they are used accordingly on different types of exams that are necessary for each one. For example, a head CT usually uses the drip infusion, and a CTA uses the bolus infusion. In the brain, most studies are performed with the IV drip method. So this allows the contrast to percolate and enhance lesions such as a meningioma or possibly even a metastasis. At least 3 to 5 minutes is required after most of the contrast has been injected to reach satisfactory enhancement of the body part. A delay in the image acquisition, up to an hour usually, can result in a more pronounced enhancement of the brain. Because enhancement persists for hours, at least 6 to 8 hours should elapse after a contrast scan before an unenhanced CT brain is performed. This will confirm that the enhancement is real and not the result of calcification or hematoma. A CTA and CTP require the opposite contrast method, which is the bolus infusion. Images are required during rapid contrast administration by a pump. So that is basically what a pump infusion is rapid contrast administration, as compared to the drip, which is a slower contrast administration. You'll often see or hear techs using an injector for administering their contrast that is using the bolus method. For the CTA and CTP, the bolus method opacifies the cerebral blood vessels. An antecubital vein and a large bore needle, usually an 18 to 20 gauge, is necessary for bolus infusion exams at a rate of 3 to 5 milliliters per second. So you're going to be pushing usually 100 to 150 mLs through the IV catheter at a rate of 3 to 5 mLs per second using the 18 to 20 gauge. The technologist needs to be extremely careful as to not extravasate contrast into the arm during this procedure. The volume injected per second into the vein should take the vein size into consideration. So if you have an elderly patient who has weak veins, or even a cancer patient who has weak veins usually, you need to make sure that you don't blow the vein by sending too much contrast through the IV too quickly. You'll sometimes need to back off on your flow rate. The technologist should be well versed about the facility's instructions for follow-up with the patient regarding contrast extravasation. Indwelling catheters shouldn't be used for pump infusion because their small gauge size cannot handle the rate of the 3 to 5 mLs per second for the injection. Non-ionic contrast has reduced the number of mild and moderate allergic reactions, such as vomiting, nausea, urticaria, but it has not altered the risk of anaphylactic reactions and death, although this is continuously being worked on. A standard dose of contrast is administered for each type of examination on the basis of the patient's weight up until a maximum point. A common example is using 3 milliliters of contrast per kilogram to a maximum of 150 mLs for both the drip and the pump methods. But variations do occur according to the facility and the radiologist's preference, and also to each body part being imaged. But usually for an adult, you will use the full 150. But the 3 millimeters per kilo rule usually applies to children. The current non-ionic contrast concentration is 320 milligrams per milliliter of iodine. Great care must be taken when administering contrast, as we've already said. Contrast-induced nephropathy can occur, which is deteriorated kidney function as a result of iodine-based contrast, and has been known to significantly increase morbidity and mortality rates. Patients who should be given even more careful consideration when giving contrast or not includes those with poor renal function, diabetics, heart patients, hypertensive patients, and other elderly patients. They should all have documented lab values before administering contrast. And these lab values include creatinine and the glomerular filtration rate. That's a mouthful. We will abbreviate this with GFR. The GFR is a better indicator of normal renal function as compared to the creatinine. The GFR of greater than 60 is normal on lab values. However, there are exceptions to checking lab values on these types of patients prior to giving contrast, which are in trauma situations when life is in danger or of bleeding, and acute stroke or when time is of the essence. Contrast media can be used in patients with multiple myeloma, but only if the renal function is normal. And even then, a follow-up of the kidney function values should be done days after the CT took place to ensure that the kidney is functioning properly. All patients receiving contrast should increase their water intake to stay hydrated before and after the contrast is administered.